After that, may I invite Dr. PIYUSH Kohli. Dr. PIYUSH is our colleague from Arvind Time and a great VR surgeon and a very hardworking person and a great researcher. I have learned many things from Dr. PIYUSH. So I invite Dr. PIYUSH for his talk, the next talk.
Okay. Thank you, Chitranjan sir, for that kind introduction. And initially, I would like to thank Jayan sir for providing me this opportunity. I will be talking about optimizing results as a beginner, role of supplements and making correct choices. So the first thing is that you should do a careful patient selection in your initial part of the career. Because initially, you have to do a careful and detailed ocular examination as well as correct patient collection is very important in the initial part. You have to build your confidence, you have to build rapport among your anterior segment peers, you have to build rapport among your staff, and you have to build rapport among your patients. So like this is a closed funnel RD. Initially, you should not jump into this. You can ignore this patient and move ahead. This is a very chronic MTRD, which even if you attach, vision will not come back. So in your initial part of career, you can ignore this. Now coming on to a few surgical scenarios. So initially, you have to treat the patient and not the eye. So if you see this patient, this is a combined mechanism RD, you will want to jump into treating this eye, but withhold, do the PRP first, stabilize the other eye, win patient's confidence, and then go ahead with the surgery. Avoid surgery if possible in extramacular TRDs, do a PRP, do add laser, reduce the neovascular activity, and reduce the probability of macular involvement. Before jumping onto the TRD, discuss that there are chances of TRD progression and involvement of the macula and possible need for future surgery. This patient, I did a PRP and eventually as the NVD regressed, fibrosis set in and MTRD progressed and I had to operate this case. Now coming on to diabetic vitrectomy, the problems faced during surgery are there can be intraop bleed and there can be iatrogenic breaks, which can lead to increased surgical time, corneal edema, cataract, reduced media clarity. We have a difficulty in performing delamination and segmentation of the fibrovascular tissue, which can lead to creation and extension of retinal breaks. It will impede your laser, which will increase the risk of post-op NVI and NVG, and you can also have post-op VH. So what you have to do, you have to optimize the systemic status, that is the blood sugar, blood pressure, renal status, and the cardiac status. But this is not always possible in Indian scenario, especially in tier 2, tier 3 cities. So you have to coordinate with the anesthesiologist for BP control at least during the perioperative period. So another thing you can do is go for anti-VEGFs in TRD. The advantages you will get is that it will induce the regression of retinal neovascularization, it will decrease the intraop bleeding, it will facilitate the easier removal of the fibrovascular membranes, it will decrease the intraop breaks, it will reduce the duration of surgery, it will give you a smoother surgery and better post-op visual acuity. So like this was a very good meta-analysis done. It showed that the intraoperative bleed, the early post-operative VH, the number of diathermies needed, the number of surgical time and BCVA at 3 months is always better if you give Avastin or any anti-VEGF before surgery. Pre-op anti-VEGF will have main concerns that the progressive fibrosis can occur in the fibrovascular membranes and it can lead to formation or aggravation of TRD. So the incidence of TRD following Avastin has been documented as 2.7% within 6 days and 56% after 10 days. So you have a gap of 6 to 10 days, you have to operate within them. And it also does not significantly reduce the incidence of siliconal tamponade. So what I do, I give a pre-op Avastin within 3 to 7 days, but before going ahead, I make sure that the patient is fit for surgery before injection, so that after the injection, there should be no surgical delay. So this is a patient after surgery doing well. So other maneuvers to reduce intraop bleed are you can increase the intraop pressure to 60, but this will lead to corneal edema, reduce media clarity. Also, it will cause macular as well as optic disc ischemia. Second thing you can do is go for endodiathermy, but it will induce necrosis and cause shrinkage of retina. One of my favorite is to go for a fluid air exchange, clear the blood, remove the subretinal fluid, inject PFCL of the macula, come back to the fluid and continue with the surgery. But obviously, this will prolong the surgery. Pre-op injection anti-VEGF will even help in VH cases. This was a study done that showed that the central macular thickness was less and BCA was better if you gave anti-VEGF in a simple case of VH also. Then what you have to do in case of DR, you have to go for multiple triamcinolone wash and ILM peeling because these patients can be commonly associated with vitroschisis. So this is a case where ILM peeling helped me remove the fibrovascular membranes. While doing ILM peeling, you will find a place and you can then remove the fibrovascular membrane. So prefer silicone oil as temperating agent, especially if you are in doubt, because if the patient goes for re-RD, the PVR chances will be less, and if the patient is single-eyed, because the patient will be happier on post-op day 1 because he'll have a better vision compared to gas. In retinal detachment surgery, you treat the eye with better prognosis. Suppose if you have one eye with cataract and RD and second eye with only cataract, so you treat the cataract eye first because this will help you win patient's confidence. The patient will get early rehabilitation. Sometimes the patient may have money for only one surgery. The patient cannot go for multiple surgeries, and happy patient will bring you more patients and vice versa. A patient who's unhappy will send back 4 of your patients. Now retinal detachment, you have to see for the other eye also, because there are high chances that the other eye will have retinal breaks which you have to treat. Now the things you can do, you can have encirclage band, you can put a 240 band, you can have a 42 band, you can do a suture or a sutureless technique. Like in this case, it's a 240 band which is done with a sutureless technique. You can make tunnels. Like you make a tunnel with a crescent and put a band. Other thing you can do, you can suture a 42 band. You have to mark, you put sutures, and then tie them off. So how does encirclage band? It will support the vitreous base. It will cover up for any poor visualization system which prevents you for good base dissection. It will cover up for your less efficient assistant. There can be multiple lattices where you are not able to induce the PVT beyond it. Sometimes lattices can get torn, or there can be accidental breaks. Then there can be poor media clarity because of corneal opacity, peripheral PCO, small pupil, or long surgical times. Then you can miss the breaks. Machine can get malfunction. Or there can be improper sclerostomy which can create more breaks. So all of these will be covered if you are putting an encirclage band. And you have to interpret the study results very carefully, because one, these studies are done by senior surgeons and not by beginners, and most of them prove non-inferiority and statistically similar results. So I will give you a few examples. One of the very important study, Viper study, which says do not put the band because it is not helpful. If you see very carefully, the success reached is 79% if you are putting a band, and 73.5% if you are not putting a band. So you have about 6 patients which you have to handle, which are going for re-RD. So it may be statistically non-significant, but it is clinically very significant. Similarly, Viper report 3, where they have put encirclage band in an inferior breaks. If you are doing encirclage band, the success rate is 77%, whereas if you are not putting a band, it is 57%. It may be statistically non-significant, but clinically it is very significant. You have to handle 20 more re-RDs. Like another study, that was the European vitreoretinal study, which says supplemental band is not helpful, but be careful while interpreting this study, because this was a study where questionnaire was sent to the other surgeons, and they sent it back, and they have themselves acknowledged that the surgeon may have chosen scleral buccal in those cases which are already deemed to fail. So encirclage band will give you a good anatomical result, which is much more important as a beginner, because the retina should be reattached after SOR. If the patient is unhappy, which is quite a high chance, he will go doctor shopping. What he needs to know that the retina is attached. If the retina is attached, he'll come back to you, and you will have to go for a resurgery, which is very difficult for you to convince, and also he will not pay for the surgery. Who will pay for the cost? This I will not recommend, but if needed, you can put a band if you are doing an SFIL and you get a break, if you are doing a macular hole and you get a break, if you are removing an intraocular foreign body and you get a break, or VH where intraretinal break. And remember, it is not compulsory that you should put a band in the initial part. You can also put the band after sclerostomy, suturing the sclerostomy. Then 360-degree barrage is also an important thing. It will treat the potential missed breaks, interops breaks during the base dissection. It will wall off the interior detachments. It takes only a few minutes. One potential complication is that it will lead to an ERM formation, but solution is you can go for an ILM peeling during the surgery. This is a study which said that 360-degree endolaser is not important, but if you see carefully, the retina was reattached in 96% of the cases if you do an endolaser, 360-degree endolaser, and in only 88% if you skip that. So you have 8 more patients to handle. This study also, single operation, if you are doing a 360-degree laser, it is 90%, while if you are not doing, it is only 87%. So, ILM peeling during surgery is not very difficult. You can put PFCL and then go for ILM peeling. So ILM peeling, there are many studies which also show that it will reduce the PVR changes and increase your surgical result. Go for a preparatory cataract surgery before VR surgery because it will give you a clear media. You have now less stress of a lens touch. You can concentrate on your VR surgery only. And also, if you expect more than one surgery for chronic or complicated cases, then go for a preparatory cataract surgery before. Assess the IOL stability and PCR because air may come in the AC after fluid air exchange. Complete the laser as much as possible before FAE. And cataracts, before going for cataract complications like nucleus drop, IOL drop or aphakia, always ensure that the cornea is clear because the patient has a potential 6/6 vision and there is no scope for retinal detachment. Although there are chances that you can end up in retinal detachment. Incidence rate, what we have seen is 1.7%. So ensure that the cornea is clear. But you cannot wait. If you are going for an endophthalmitis surgery, you have to remove whatever comes in way. You have to remove the corneal epithelium, fibrin, iris, lens, IOL. Suppose you get this case with endophthalmitis, you have to operate. You can remove the IOL, you can remove the epithelium. This is a case, traumatic case. Sutures are in between. You have to cut the iris, you have to cut the lens. And if a large intraocular foreign body you are facing, you can sacrifice the lens in these cases because enlargement of sclerostomy is associated with complications like hypotony, CD, VH, retinal incarcerations. You can remove the via limbus also. This was a patient with a very large foreign body. I tried with a 23 gauge, it was not coming out. Tried with a 17 gauge, now I have to go through the scleral tunnel and remove the foreign body. So always make a good rapport with the patient, explain the common complications to the patient. You may lose a patient, but you should not lose your reputation. Answer their questions, talk sweetly to them. Patient may not always be right, they can be liars, but you have to reevaluate, you should not argue with them. You have to make a good rapport with them. You have to make a good rapport with the anterior segment surgeon. Sometimes you may need to help them. This was a case with the superior DMD as well as an aphakia. You can go for an SFIL via the temporal incision. Here I have,
Dr. Piyush, you can wrap up fast.
Thank you. Thank you. To recall, it is important for patient selection. You can go for pre-op anti-VEGF injections in cerclage band, 360-degree bands in a case of RRD. You can go for a preparatory cataract surgery, detailed assessment of the IOL stability, adequate corneal opacity before managing cataract complications, and good rapport with the patients. Thank you.
Thank you, Dr. Piyush, for that wonderful talk. You brought out one very important fact that we should be careful while interpreting the studies and look at the data in studies carefully.